lovely to chat with a scientist and someone from EUROIMMUN testing that we use for NMO and MOGAD. And we have obviously Dr. Abbatemarco from a clinical side. So this will be, I guess, a bit of an interaction between sort of science and clinicians. So I don't know if, Iswariya, do you want to talk a little bit about your role and what EUROIMMUN is so that the audience understands?
Hello. Good to go. Okay. Thank you so much, Dr. Kunchok. You pronounce my name so well. And before I begin, I just wanted to say this is my first patient day with NMO community. I have been doing for the last 10 years a lot with autoimmune encephalitis patients. So thank you, Sumaira, for graciously accepting us into your organization, and I hope we can do a lot more together, you and Michael and the entire TSF team. So my role is, I come from the medical diagnostic company, as Dr. Kunchok said, EUROIMMUN, and we provide diagnostic tests for many of such conditions, not just NMO or MOGAD, but also primarily autoimmune encephalitis, paraneoplastic syndrome, now recently CIDP. We have discovered over 50 different novel biomarkers. I come from that R&D lab, so I'm proud to say that we are continuing to discover novel biomarkers, and one of the goals that we have is to work with people like Sumaira, and so that we can try to understand what other markers are in the patients who are double seronegative, who are here together with us today. So my role in this company is education, awareness, making sure that right testing is available in North America, and speedy diagnosis. That's my biggest goal, so that patients, I think I met with Kayla this morning, and people should not have to go through 7 months, 10 months getting diagnosed, so hopefully we can help improve that. So long version of my answer, but that's what I do.
Maybe we can talk a little bit on the clinical side. Dr. Abbatemarco, in terms of diagnosis, we covered this a little bit earlier in the panel, but maybe we can go into a bit more detail. When you first encounter a patient in the clinic, what sort of process do you go through clinically prior to the testing to work out stratifying what tests you might do to diagnose?
Yeah, I know we talked about this a little bit in that beginning panel, and then I think hearing from patients, it's the most powerful, right? In this diagnostic kind of odyssey, sometimes is how I describe it. I think patients experience this winding journey. It starts with the patient, right? Trying to listen to their story. Again, we've talked about those common symptoms, eyes and spinal cord involvement. I think one of the tools you're going to hear us talk about all the time, right? MRIs are kind of central to our kind of way to peek in to the brain, spinal cord, to be able to see it in a different way, and we're looking for kind of specific patterns of inflammation that help us kind of diagnose MOGAD, NMOSD, and then differentiating it from MS. The lab test, which is, it's so great to have someone from this end, right? Because patients don't get to see all the testing and the technology that goes into that element. So usually we're using blood tests for NMOSD and MOGAD, but they need to be sent to the right place with the right expertise, right? These are rare disorders and are hard assays to run. And so having patient access to that is really, really important. And hopefully timing those things up. So we have a couple of those kind of fancy terms up there, which again, I think you should be partnering with your clinicians to kind of talk about, is it the right test, the right place that's being sent to make sure that we get to the right diagnosis early. And then trying to pull all that information together, right? And sometimes I use that analogy of like a puzzle when we're making this diagnosis, right? The history, these MRIs, these other tests that we're using, the lab tests, in order to get to the bottom of that diagnosis and getting on that right treatment, which is, I think, a moving target for us a little bit, especially in MOGAD, but so much more to come.
If I can add a little bit to what Dr. I cannot pronounce your last name, Justin said, and I think it'll be the same. You'll have a tough time pronouncing my last name. So I'm not a clinician, but I'm in this field since 2014, more from a research scientific standpoint. I think for disorders like NMO, MOGAD, and clinicians around me can agree to that, it's really good that there is at least 2 of the tests which is able to detect the condition, and both of them are blood tests. So if if I play my role right, and if my organization plays our role right, once we educate clinicians, physicians, even emergency doctors around the globe, this should be an easy diagnosis. The one thing that I want to educate is, like Justin said, please do talk to your doctors about the techniques, because this is a situation that you have that I put up on the slide. So when you go to the hospital, after several of those tests, you do get your blood drawn, and they test you for aquaporin or MOG, one of the two known autoantibodies in this field. And then this goes to the laboratory, which is where we come into picture. In the laboratory side, you want to talk to your doctors what kind of testing they're doing in the laboratory. And this is the data that I've derived from a publication that was released last year. So again, it's not me saying, it's publicly available literature. So there are some assays which are not suitable for testing this type of a condition. That's the first category, like testing them on tissues or any other immunoprecipitation methods, whereas there is two other types of assays which are called cell-based assays. There can be a live cell-based assay and a fixed cell-based assay. I'm not going to go into details of both, but talk to your doctors what type of tests you're doing, and according to guidelines, which many of the doctors here have written, they do recommend looking into cell-based assays for this particular type of disorders. Again, if you talk about autoimmune encephalitis or paraneoplastic, there are others, but NMOSD, looking into cell-based assays. So please be, like I think Nikesha said that very well, please go with a list of questions to your doctors so that you can ask them about all of this.
I wonder if you could talk also about EUROIMMUN and research into seronegative NMOSD and what possibly the future might hold there.
Yeah, sure. So like I said, I come from a very unique organization. We pride ourselves as a neuro company because we work a lot on R&D trying to discover novel markers. So far, 50 novel antibodies. Most of them are in the spectrum of autoimmune encephalitis and paraneoplastic syndrome. We have not done it in the NMO space. We have proprietary methodology protocols that we try to understand what is this novel marker that this patient has, which could not be detected in all the other tests that are available in your hospital or the laboratory. So this is basically what we do is we have a collaboration study with the physicians because they are the key to getting this setup done. And then mainly we would need the samples from the patients so that we can include your samples into our research study. It's very different from a clinical trial. Research study is done from a lab standpoint. We don't ask you to come into our lab or anything like that. It's just your samples. We try to see what is the sample actually targeting in your brain or in a lysate of a brain tissue, which is animal derived. And then we try to pull it down. In simple terms, we use your own antibodies to pull the target out from a brain lysate, from an animal tissue. And then there is other technologies, which I don't want to go into science, but we try to identify what is that target. And then we have to then go collaborate with clinicians to validate that target so that we can bring it into a laboratory for future testing. So it takes about, let's say from a ground zero phase, discovery to launch, it can take about 5 to 7 years to get something like a novel marker into the market. But without the help of clinicians, it's just impossible because we need to be able to validate, does this marker, new marker, has any clinical significance? And if yes, what is that? So that's where all the clinician partners are really important for us.
Thank you. So I think in summary, we've talked a lot about the testing and how important it is to have some blood testing and done in a really good way with cell-based assay, and there might be some interesting research in the future that will help to identify other antibodies that might also be used for diagnosis. Just to recap from a clinical side, how this kind of fits, how this blood testing and this complicated science fits into our work clinically. I think when we typically see a patient, I think of there being sort of 4 parts to evaluate evaluating a patient. We start by, as Dr. Abbatemarco said, taking a history, which means talking to the patient, finding out what's happened, what are their symptoms, what parts of that fit with NMOSD or MOGAD or another disorder. We're always keeping our eyes open if there's something else that could be mimicking NMOSD or MOGAD. So we spend a lot of time talking to patients. Then many of you may have experienced the process of being examined. So we look in people's eyes, we maybe hit some reflexes and test strength in the limbs. So that, I think, of the second part of the evaluation is the examination. And then the third part I think of as imaging, which Dr. Abbatemarco mentioned. MRI imaging is commonly done, but we also do some other parts of testing in the investigation, often before we get the lab results back, which I think of as the fourth part. So just in the investigation side, I mean, in addition to MRIs, I just wonder, Dr. Abbatemarco, if you want to talk about maybe things like OCT or lumbar punctures, or other types of tests that patients might go through as part of their kind of diagnostic odyssey through the process of being evaluated.
Yeah, and we can definitely talk about those. So we have this kind of puzzle piece that we're putting together. I think a lumbar puncture is definitely something really common, really scary when we talk about that, right? Who wants a needle in the back? I think it's a really scary procedure, but you know, sometimes when I describe that to patients, right, we use blood and when we have diseases that affect the body. But when we had talking about the brain and eye, right, we want information from that area. And so the lumbar puncture allows us to pull off a little bit of fluid from those areas to give us information on what's going on in that area. The blood-brain barrier is this really tight kind of junction that makes it a little bit harder, so that spinal tap allows us to take some fluid off that area, test it, helps us with this kind of diagnosis between all of these different diseases. NMO, MOGAD, and even MS have very different signatures to help us figure out what is kind of going on. We talked about some others. So MRI allows us to kind of see X-ray vision into the brain. But we have some other techniques that are emerging, some that are a little less invasive. I'm sure many of you guys have gone through. MRI is not fun. And so we've been working on OCT. You know, the eye is the window to the soul, but it's also the window to the brain. And so this allows you to have like a quick picture in the office setting with your ophthalmologist to kind of look at the eye in a different way. And I think we're going to see this used more and more in the future as some type of a marker for disease activity, monitoring how patients are doing, right? We heard from one of our patients about having those eye symptoms, right, and not being able to see much, but the OCT could maybe give us a clue right away, those first couple of days with symptom onset, and then give us a way to monitor the disease moving forward. So many kind of different avenues to kind of monitor the patient, put together that puzzle piece to get to the diagnosis.
Thanks. Yeah, so it's a bit of a process as a clinician that we go through to try and work out whether a patient is likely to have NMOSD or MOGAD, and putting together all the parts, what a patient's history is, what they look like when we examine them, what the tests show, and then most oftenly at the end, then there's also the antibody testing, which is really important in sort of clarifying which pathway people might belong to. So a really important area. Do you have any final comments that you want to mention about your testing that EUROIMMUN are doing?
Sure. So maybe one last slide that I brought was something for the patients, right? And this follows up with bringing a list of questions. I think previously when the physicians were talking, it was important that these antibodies might reduce or disappear if you're on treatment. So if you're already on treatment, you might be negative for some of the antibodies, but that doesn't mean this was the cause. So if you're starting treatment, just having that level of information so that there might be, you are not antibody negative, but the antibody was reduced because of the treatment. And then looking into the methodology as I discussed, but also from a laboratory standpoint, how did they look into testing for these two assays, whether it was a live assay, fixed assay, or did they do an ELISA, which is not acceptable in this whole case. So all of this information is critical for the patients. And the good part, again, for particularly NMO is it's enough for a blood test, and you don't need to, the guidelines also don't ask you to look into a CSF, so it's an easy to do blood test. So this is, again, something you can discuss with your doctors and clinicians. And one last thing about EUROIMMUN is the test we offer is the fixed cell-based assay. It's easy to perform within 3-4 hours. you should have your results very easy to read, and that's a mock-up picture that I brought here today just to show you. So we hope to continue this level of neuro expertise and try to identify more markers, and so that we can get a diagnosis for patients early on.
That's great. Thank you so much for that summary. And the testing is such a important part, and it's so great that your company or the company that you're working for, EUROIMMUN, is doing all this research into extending the boundaries of what we know already. So I think that this space will probably change as we understand more and more about what antibodies or that we don't know about are out there. So thank you. I think that's it, but we can move on to the next session. Thanks so much.